So my name is Alex Mohit. I practice down South Sound, and I have a history with a lot of the people in this room. It was a hard ride to get up here this morning. We had to leave at a crack of dawn to get here. Today the talk is about something that I'm very, very passionate about. It's on surface technology and implants that we use on a daily basis. And so here's a foray into implants. So a little bit about my disclosures. I'm a consultant for Globus Medical and posterior cervical systems, and I'm also a consultant in sacroiliac fixation, lumbopelvic fixation for K2M spine. I receive no financial remuneration for anything that's related to 3D printing interbody spacers. So after years of developing slab titanium implants, essentially machining implants out of titanium rods. And if you've ever visited any of the companies that make these implants, they start with these rods that are quite long, and they put them in presses and they hammer them. It's like Thor just banging the hammer on top of these things, and they create a shape that's out of the titanium metal. They do not melt the metal. Okay, so the metal stays intact. They just machine it and they reassemble these devices. So we are learning from joint surgeons, orthopedic joint replacement surgeons, about implant porosity. And I think they're way ahead of us, and also craniomaxillofacial surgeons in terms of what implants should be, if they're porous or not. We've been putting in these metallic pieces that their porosity is not something that we've ever really looked at systematically. So the pictures that you see here are acetabular cups, and they have found that pore size is important, and about 500 microns is sort of the magic size, and that allows osseointegration, osteoblasts to go in there and make nests, and actually the device attaches. So in the years past, when you had a hip replacement, they used to ream your acetabulum with a sort of a device, and they used to take a little bit of a PMMA, which is polymethyl methacrylate, and it's a glue, a surgical glue, and you just actually paste it on top of that, and then you take your acetabular cup and you shove it in there and let the glue harden, and that would be the device. And then you put in your ball and the joint. Now things have gone to press fits, so they use a very soft broach to bloody up the acetabulum, and then they just press fit these devices, and they don't use any glue. In the knee, they still use glue, but in hip replacements, the glue has pretty much been done away with, unless you have a revision case. So the pore size is really important. So emphasis is, this is called pore size matching. Match the pore size of the implant to the underlying bone. So how does 3D printing come into play? Why is it important to even think about this technology? Is it just that companies saves them money in the way they they make these implants? Actually, no, that's not the case. 3D printing allows you to make any implant in any way you want. You can dream it and you can make it. There's no constraints about taking a tube of titanium metal and hammer it into an implant. So this is, I'm going to show you this again. This is actually a laser that the stuff that you see down here is just powdered titanium. So powdered titanium is manufactured that way, extremely flammable because of its surface area. This is in an argon environment, and the laser basically etches, it connects the little beads of titanium together by sintering them together. And a computer is driving the action of the laser. And you can see, you can make a lot of implants pretty quickly. And so the next layer, so this is called lamellar technology.
Can I ask you what's happening there? What are they doing with that?
What's that?
What's happening there when they're doing that? They're putting
So-
a layer of something on there?
So basically this is just powdered titanium.
Okay.
Okay, so it's like grounds of pepper.
Okay.
This is just a tray that has powdered titanium. You can actually put your hand right in there if you could get in there and not catch fire. So this is under an argon environment. So this is argon, so there's no air inside the system. The laser is being driven by the computer, and basically it's these shapes. These shapes are the lower layer of the implants. So there's another layer of titanium on top of it. You can see the impressions in it. So the laser comes around and it basically connects the old implant that's just below the surface to, so it basically makes it in layers. And that's why it's called lamellar titanium. So inside, the way it does it, it can allow pore integration into the system. So you can make it in any way. So what's the optimal implant? It has to have porosity. We know that from the literature review that pore size is important. These are basically preclinical studies and in vitro studies. So there's obviously no human studies that has been done about pore size matching, but I think we've extrapolated some of that information into designing new implants. So 300 to 700 microns appears to be the magic range. So porosity, you can see here, I don't know, can you see the mouse there? So basically you can see that that's an implant out there, just that that implant happens to be something called Cascadia from K2M, and this is a 3D scanning electron microscope. So the round circles are the pore sizes. They're uniform in size. We're not as sophisticated as God that we can generate variable size pores in an implant. I'm sure we could probably reach there because we can basically integrate our thoughts into the computer, and the computer can tell the laser what to do. So there's really limitless possibilities. But the porosity is actually the holes that you're talking about. The stuff that you see outside the holes is called roughness, and we'll talk about that in a little minute. So roughness is the second characteristic of the implant. Why is that important? So roughness is important for the osteoblasts to integrate into the underlying bone and to nest into that area. So the literature review shows, again, preclinical studies and in vitro studies, that 0.5 to 20 microns is the magic number for osteoblastic integration. So this is the implant Cascadia, again, from K2M, and this is a scanning electron microscope, and you can see in two different magnifications on the left. So that's the pore sizes, and the trabeculae that you see between the pores is higher magnification, is shown right here. You can see it's not smooth, it's tough, it's rough, and that roughness is important. And this is the way the implant looks when you're actually holding it in your hand. So the third feature of the optimal implant is imaging characteristics. We all image our patients after we put in implants. So we put in implants, we get subsequent CTs, subsequent MRIs, and subsequent X-rays. So it's really, really important to see how they compare to what we already have. So imaging, you can see here on this, what we really want to achieve is less streak artifact. I don't know if anybody here has seen what a CT looks like from an artificial disc. So most artificial discs are generally a hunk of titanium. They tend to overwhelm the picture. So if you get a CT scan, it looks like there is just streaks it's like beams of radiation coming out of the implant that obscures any visible or useful data at that level. So this is a CT, and what we really want to see is less streak artifact. We're comparing PEEK. PEEK is polyethyl ether ketone, and that's basically plastics, polymeric plastic. It's our go-to, it has been our go-to implant for several reasons. It mimics stiffness that's similar to bone, and also that it has very good imaging characteristics. So it's really used in tumor cases. So when you know you're taking a tumor out and you're putting an implant and you're reconstructing the spine after your tumor resection, you want to be able to re-image that patient after they've had their radiation to see if tumor has recurred. So PEEK has been our go-to. This is Cascadia, which is lamellar titanium. So if you ever look at a Cascadia implant, you could actually see through the implant, okay? If you look at a slab titanium or solid titanium, it's going to be difficult. Now, there are different designs of the slab titanium. Some have more titanium than others. So artificial disc has a lot of titanium. So that's going to have a huge streak artifact. But the less streak artifact that we have, the better it is. So MRIs is also important, again, for tumor characteristics. So if you've ever seen an MRI in an artificial disc, it doesn't look like streaks. It looks like a blob of blackness. So it's like a black hole that just emanates from the implant. You can't see any neuroforaminal, you can't get any neuroforaminal information in somebody who's had an implant placed and you're trying to see if they had any neuroforaminal compromise. Even when you do your ACDF and you're trying to see that there's any residual or recurrent neuroforaminal stenosis, you're not going to be able to see it because it obscures it. So again, this is the gradation. T2 MRI, this is a 1.5 magnet, and a T1. And you can see in solid, it tends to give you the biggest blob, and PEEK tends to give you the least amount of blob. So the stuff that you see, there's just these intermittent hypointensity, but the blob of hypointensity, it emanates from the implant. So what we want is something that has sort of combines all these things that our ideal implant should have into one device. So the fourth feature is stiffness. Stiffness is important because the more stiff stuff we put into it, especially when you're dealing with an osteoporotic patient, you're going to get complications. You're going to get subsidence. You're going to get collapse. So I know a lot of you probably have heard about modulus of elasticity. Modulus of elasticity is not really a useful term. Modulus of elasticity is a biophysical property of a substance. So it's really unique to that substance. You cannot change the modulus of elasticity of a substance the way you design an implant, okay? So you can take a titanium implant that's slab titanium that's machined by Thor, or it's 3D imprinted, and it has the same modulus of elasticity. Because if you've ever gone in a lab and measured a modulus of elasticity, they take a tiny piece of the implant and they put it in this machine, and that's how they measure it. So the implant design itself has no bearing on it, and it has no useful information. A better term to use is stiffness, okay, and bendability of the implant, okay? So let's look at stiffness values. PEEK, remember, is our sort of implant that we've used for a very long time. So a good question is, for you non-surgeons out there, why not use PEEK? PEEK seems to be pretty good. Why don't we use it? And I have a slide to show you. PEEK is hydrophobic. The bone growth environment is hydrophilic. We tend to get encysting or cyst formation or a blob of something around a lot of implants made out of PEEK. So it doesn't integrate into the adjacent end plates. I'm sorry?
He gets a lot of the blob.
Just to give you cases.
So PEEK is an optimal implant for two reasons. One is imaging properties, and two, its stiffness is similar to bone. Now, if you look at lamellar titanium, it is more similar to PEEK than it is to its big brother, slab titanium. So this is actually probably more useful or similar to PEEK. And this is cortical bone right here. So cortical bone is actually similar to titanium, slab titanium. So from a stiffness point of view, lamellar titanium seems to fit a lot of these characteristics which we've been searching for. So this is the PEAK slide that I actually talk to people about, but there are true believers of PEAK out there. It's almost like a cult now, that they refuse to let it go. They just hold on to it despite data. They just say, don't take my PEAK away. And this is something that you see in spine meetings. So this is a histologic evaluation of bone growth into implant. PEAK is liquid, it's meltable. You melt it and you pour it into a cast and you let it harden. There is something new on the horizon that people have talked about. It's called porous peak. Porous peak is just like volcanic rock. So if you fast cool it, it'll have bubbles of air in it. So if you've ever been to Hawaii and you're actually looking at these pieces of rock and you break one, you see it's porous. The reason is it was really hot and then it rapidly cooled. And then the air got trapped. So that's basically how the porous peak is made. But nobody has really studied its use in vitro, preclinical, or in vivo. It's basically, at this point, is being driven by industry, people that are making it. So we don't really have any data that I can say, oh yeah, porous peak is great. But this is regular peak. This is looking at a New Zealand white rabbit implant at 6 weeks and at 12 weeks. It compares, that is peak, compares it to lamellar titanium. I will use the term lamellar to 3D printed interchangeably because basically it's just, lamellar is just one layer at a time is added in the 3D printing machine. And you can see at 6 weeks, they don't look that different. So what is bone and what's implant? This is implant, this is implant. The brown is bone, okay? The brown stuff. So this is the bone implant interface at 6 weeks. They really aren't that different. There is a little bit of layer of sort of nothingness between the implant and the bone. But, you know, you could argue that that's just an artifact. But this is more integrated. But at 12 weeks, the differences are very different. So you can see little bits of bone, and this is that blob that we're talking about at peak. And then look at the ingrowth of bone at 12 weeks in the lamellar titanium. So, other things you can do, you can basically, as I said before, you can dream it, you can make it. You can make custom implants all the way to patient-specific implants. This particular thing is an implant made for a sacrectomy patient that Zia Gokaslan did, and this is an implant that was made before the surgery was performed. And if you've ever seen a sacrectomy, I did a few of them in my fellowship, and I can tell you it's quite a morbid operation. Not only during operation, but also the recovery, because you have to reconstruct the sacrum. And that's, sacrum, if you think that it was just a piece of bone hanging there, it has huge biomechanical properties. It's really the back door of your pelvis. Without it, the pelvis will fall apart. And this is basically an implant that is made in the 3D printed machine. So the surgeon had the sacrectomy, the patient had the sacrectomy done, and this is put in on the back of the pelvis, and then is screwed in with HA-coated, hydroxyapatite-coated screws that attaches to this point, and then rods come down basically from the top of the construct, and they attach to these, okay? So that's basically a 3D planted, so imprinted. If you do this in a slab titanium, you'd be working for probably about years. So I'm old enough to know what the basement of Lutheran Hospital looks like in Cleveland, where Art Steffi used to actually make pedicle screws. And there's machines that are, you know, presses and hammers and awls and things like that. So those days, I'm hoping, are gone. So we'll talk about a few case examples that I've been using, and I've been a slab titanium user and PEAK user for many, many years. So now I've basically have made the transition slowly and begrudgingly, but what I've seen so far, I have very satisfied. So this is a 54-year-old man with myelopathy. And you can see this is a sagittal MRI, and the myelopathy is pretty obvious. And these are axial images, C3-4, C4-5, C5-6, and C6-7 at the level of the foramina. He's got cord compression, cord signal, and obvious myelopathy. So what would we do for this gentleman? Now, normally, doing an anterior operation addressing all those levels in the past would kind of send shivers down my spine. Most of the pathology is anterior, so it would be better for me to go anterior. But a lot of us, because of the fact that we don't want to do multi-level anterior, because we get a non-union at usually 1 or 2 levels. So we get a nice fusion at the top 3 levels, and the 4th one is a non-union. So what we did for him was this, which was a 4-level ACDF, and we put in these ACF spacers, and this is the lamellar titanium implant and the plate. So essentially, I was worried about doing these for many, many years with PEEK implants and slab titanium implants, but I don't think I'm nearly as worried. I do get to sleep at night. So I don't have, this is 3 months post-op. I don't have a long-term follow-up on him, but I have a long-term follow-up on this gentleman who had a 2-level ACDF about a year ago. I didn't have his pre-op images, but you had a question.
What do you put in the cage?
I'm sorry?
What's in the cage?
So when I get in there, and I usually drill with a Midas, and I drill the osteophyte down and take the uncovertebral joint, I just scoop that up, and I actually just pack it into the cage. And the good thing about it is this: if you squeeze it, you actually see the bone percolate into the cage, because the pore sizes are completely throughout the cage. So this is a pretty good fusion at a year.
Yes.
So this is another case, which is a 69-year-old gentleman who had a 4-to-1 fusion performed by me 3 years prior for spondy. So this was a slab titanium. This cage is a expandable cage, and this is a coronal view. So I'll show you a high mag of this, but you can see there is a bony, there's a sort of a cavity of nothingness around this cage. This is a floating cage. But we do have posterolateral fusion. I used to rely a lot on my posterolateral work. I did a lot of posterolateral work to get my fusion. But I think with this stuff, having so much confidence in the inner body level, I don't do as much of it. So this is what I tend to see right here. It was soft with him. But he developed adjacent segment disease. He had hip flexion weakness. He couldn't weight bear. His knee was collapsing. So after doing conservative care, obviously it didn't help. He has compression, and he has his fish mounts when he stands upright, or he bends backwards in the CT scanner. So this is what his axials look like, 3, 4, 2, 3, and this is that coronal high mag. You can see the bone or the lack thereof around this cage, and it's floating right here. And you can see that, and that's obviously not the best result for a $5,600 cage. So what did I do for him? So what we did is we did a 2-level lateral operation for him. So this was a challenging lateral plating, because as you saw before, he had significant osteophytic changes at the level above. And on these operations, as I was telling Rod, I actually pulled the psoas back. I don't really go through the psoas. And so I'm actually retracting the psoas back. So I'm either drilling or I'm biting away these osteophytes. But putting a plate on can be sometimes challenging if you have a lot of nooks and crannies and things like that. So you put it where you put it. Now there is a new system out there that I'm using from this with when it has an integrated plate, which makes my job easy because it just attaches to the implant. But this is what we did for him, and he did quite well. In fact, post-op day 1, I'm seeing him walk down this aisle. He's actually carrying his walker. And I did a lot of work, basically pulling the muscle back. And usually I tend to think that the more work you do, the more morbidity a patient is going to have, yanking on their muscle. But he felt so good, he's actually carrying his walker in front of him. So I took it away from him. But basically, these patients end up going home next day. So that's what he got, and long-term results will tell us more. So cases since January of 17, I've done 155 T-lifts, 40 ACDs, ACFs, and 6 L-lifts using these implants. My complications have been 1 insufficiency fracture, 2 seromas, and I define a complication by taking them back to the OR. 2 seromas, 1 infections, and no non-unions yet. Very important, I don't use any infuse at all in these cases. I used to use infuse when I used PEEK and slab titanium, but I don't use any infuse anymore.
What are you using?
So, nothing, just bone.
But I mean, for the lumbar spine, are you using local bone or?
Local bone, all local bone.
Okay.
So what I do is I usually just osteotomize the facet if it's a redo, and I just chop that up and I put that in. And sometimes if I have to get extra bone, I usually aspirate the crest and mix it up with allograft for doing a little bit in the gutters. But as I told you, I don't use much gutter bone anymore. So I don't tick the multifidus down significantly out laterally, which cuts down on morbidity, and I just decorticate the lateral edge of the facets and just the proximal part of the teepee, and I just lay the bone down on that side. So this is my insufficiency fracture. This is a gentleman who had a 2 to 5 with 3-level T-lift, and he did fine. His indications were a flat back, and he was kind of pitching forward and couldn't walk very far, and he had a spondy at 4-5. So basically this is what he ended up getting at 3 months, and everything was going well. He came and went, and he was happy with the surgery. 9 months into it, he called me with pretty quick, rapid onset of low back pain down low. And as you can see, this is a coronal view. Right here is his insufficiency fracture, going around screw to screw. So this is incorporation of bone through the inner body, incorporation of bone through the inner body, and you can see this is the inner, the lateral mass, or the lateral gutter bone that I left here. It's not very much, and it's not integrated dramatically because I just really don't do that much work there. And this is a sag, and you can see pretty good integration of bone at all the levels, at the inner body level. So what did I do? I took him down to the ilium. So I wanted to put an interbody spacer here, but I didn't have a solid base here because of the fracture. This piece was mobile. So I left that and took him down to S1 and the ilium, and got pretty good screws. And his bone is relatively good. As you saw from his T-score, he was on the positive side. He's a 70-year-old man. And basically, 3D imprinting, 3D printing of the inner body gives us pore size matching, surface roughness, gives us less radial opacity, and the stiffness that we want in an implant. Thanks, guys.
Thank you.